Thank you, Dr. Meyer. We're very keen on Health Canada's involvement and look forward to Bill C-51. I'm very pleased to be able to present Dr. Gideon Koren as the founder and director of Motherisk program and a professor of pediatrics, pharmacology, pharmacy, and medicine. What he has to say to us is more important than what I say about him. He's a legend, and we're just very pleased that he's here.
Thank you for holding this difficult hour where 7.2% of our blood goes to the right place, and it's appreciated. The big issue is what physicians know and how they put it back to patients. That's the real issue that we are talking about today. But there are problems. Of course, the labeling is that document that allows you as a prescriber to give the information to your patients. It's always part, the pregnancy labeling is always part of the labeling of the drug itself. And it is prepared by the pharmaceutical industry, given to the regulators to say yes or no. That's the rule. But here's the issue. Very rarely there is any information about pregnancy. So if there is no information about pregnancy, what can the manufacturer say? Moreover, in 90% of the cases, the manufacturer is not interested in pregnancy. The last thing they want you is to take the drug in pregnancy because you will sue them. So they want to say one thing. The drug is not shown to be safe, so don't take our drugs. Sometimes it's even more cynical, because millions of women take the drug in pregnancy and paying for it, and the companies sit on the fence. They didn't label it, so they don't take risk, but they harvest the benefits. I will not give examples, but there are indications such as morning sickness, where companies made a lot of money, although their product monograph said, we're not sure it's safe in pregnancy. So this is where we are. Of course, none of you as an adult who is not pregnant will take a medication without knowing that it works. And your physician will open a product monograph and say, there were studies to show that amlodipine will control your blood pressure and so on and so forth. But that's not true for pregnancy for the reasons we said. And of course, the reason companies don't want to do anything is the fetus. There's another patient there, and I do not blame them. You cannot, in a democratic society, cause someone to put into the label something they don't want. If you develop a new car, you tell us what it works for and how it works, and you take responsibility for what you say. So we have a tension here. We have an issue. If you want, a clash of two value systems. We want to help women, but the manufacturer may say, thank you guys, I didn't do it for pregnancy. So why do you come back to me to ask for anything? Well, you heard from Don Davis, only half of pregnancies are unplanned. A lot of women didn't know they're pregnant. So although the company told them, listen guys, if you talk a product into pregnancy, it's your problem. We didn't tell you to take. We still have a huge problem. What do you do about it? Now, many women have conditions for which they need medication, even if it's not that they missed the last menstrual period. If you have morning sickness, and we'll give this as an example in a minute, and you work in an emergency room, or you're a PhD student, or you're a scientist, you need to work. So you hope that there is a medication that will allow you to go to work. The same is with chronic conditions. No one will tell a woman to stop her epilepsy treatment in pregnancy. She will have seizures. But the company said, sorry guys, we are not there. We didn't label it for pregnancy. So you are on your own. So we are in a very unusual situation that when women are most vulnerable, they are on their own. Everyone cater women all their lives. Most advertisement go to women. Everything is woman-focused today, but not in pregnancy. Pregnancy, you are on your own. That sounds like 15th century to me, actually. Of course, it all goes down to the embryogenesis time where drug or chemical can arrest a normal procedure and cause malformations. And there is huge anxiety of birth defect that goes back to this baby, the thalidomide baby. Thalidomide was catered during the late 50s of last century for morning sickness. It's a very good antiemetic with relatively few side effects. So ideal. How on earth anyone would put such a drug on the market? At that time, the medical community believed that drugs do not cross the placenta. What's happening in mom doesn't go to baby. Why on earth people thought that a syncytium of one cell, which is the placenta, surrounded by two lakes of blood, why a one cell will not allow small molecules to cross? The same molecules cross the GI, they cross into the brain, they cross into the eye. Why would it stop there? But the reason I'm bringing it up, because the medical community that's supposed to be the most avant-garde actually is one of the most conservative groups on earth. What you learn in medical school is very difficult to change. So it took forever to change that approach as we talk today. And then, of course, as you heard from Morika and other, the reaction was, if thalidomide is bad for you, every drug is bad for you in pregnancy. Every drug is thalidomide. And there is always someone that will tell a pregnant woman not to take drug A, C, or F, because look what happened. Although, who said that it caused it? There's another falsehood that comes from that thalidomide story. They thought that nothing crossed the placenta. We know now that almost everything crossed the placenta. There are several large drugs, polar drugs, that will not. So to date, people say, if you open the CPS and look what the labels say, almost always say the drug crossed the placenta. Wow. So the physician at Northern Alberta or in the Yukon or in Toronto say, wow, the drug crossed the placenta. That's not good. Well, that doesn't mean anything. So here is, the label has a falsehood. The fact that it crossed does not mean anything pharmacologically yet. And a drug can cause damage without crossing the placenta. It can ruin the placenta itself. So it's not that per se. But that's an example of the type of perceptions that we get from those. Let me look at the depression in pregnancy issue that Adrian brought up and our Dr. Davis brought in describing the American system. Of course, depression is very common. Up to 20% of pregnant women. You may think that this is exaggerated, but several years ago, Irena Norman in our program started to ask every woman that calls us if she has depression, and there are formal ways to look at it, the Edinburgh and other scales. And indeed, a lot of women don't even know that they are depressed. They call it other things. They don't feel well. They are they are dysphoric. They are not feeling well. They are anhedonic. They don't call it depression. And there are a lot of issues that were raised with depression, but the fact is that you have to treat those women, and several speakers talked about it. The risk of not treating women is huge, and I know that Alicia will talk about it much more. The reason I bring it here in the discussion about labeling is the following. Here's the labeling for Prozac in the year 2004, 20 years after it hit the market. Safe use in pregnancy has not been established. Therefore, it should not be administered to women of childbearing age unless, in the opinion of the treating physician, the expected benefits markedly outweigh the risk. This is what you find for 90% of the drugs. That's what I said sitting on the fence. That's the company saying, it's not the company, it's the lawyers for the company, keep themselves out of trouble. But you will agree with me that most practicing physicians see this as an alarming. But that's not the big issue. Is it really true in 2004 that nothing was known about Prozac 20 years after? Well, at that time, There were 6 dysmorphology studies, including our own JAMA study in the early 90s. There were 3 neurodevelopmental studies, Irena Nullman's studies in New England in 96. That's a good journal. 1 meta-analysis that linked it all together. All those show Prozac to be safe. So how come you can tell me with a product monograph that supported by the government that we do not know? Can you imagine a similar situation in the auto industry? How long it will be before there will be a class suit against industry for not telling us the truth? A day? A week? But not in pregnancy. In pregnancy, women are in the 15th century. Even today, when we have CEOs and leaders, head states in many countries, but not in pregnancy. Pregnancy, we are still in the 15th century. Well, this bothers a lot of us. And here's the biggest frustration of them all. In 1978, the FDA, trying to put sense into it, decided to put risks to drugs based on an ABC system, which is always good. It's simple. People can remember it. A means appropriate human studies found no risk. That's the best. Very few drugs have an A because no one does randomized trials in pregnancy. It's very difficult to do. B, and of course it's descending order, insufficient human studies. There are some, they're not great, but the animal studies systematically done as part of the submission of the drug are fine. They didn't show anything, even with huge doses, generally up to 1,000-fold above human exposure. There's another option for B, that human studies are okay, but animal studies show issues which are yet uninterpretable. I'll give you an example. Animal studies can say for nifedipine that there are problems with the tails of the rats. So what are you going to tell your patient? So here's some ambiguity. What do we do with tails? Most people don't have a tail. Yeah. C is the most important one, simply because 75% of all drugs are presently at C. So a system that 75% is in the C is not a working system. That means basically we don't know enough. There is sufficient human studies. Animal studies show some potential problems. Or no animal studies, but insufficient human studies. Any of the combination. So a big cloud of I don't know. I don't know what to do. So if 75% of drugs are C, and the woman really needs a C drug because she has epilepsy or she has depression, what do you do? How can you practice that way? D, of course, get worse. Human studies showed, even with or without animal studies, that there is some fetal risk. Example for D today, valproic acid cause malformations. Why is it a D? Because many women may need valproic acid. So there is kind of risk, an attempt to risk benefit. Not ideal, but it's there. X, of course, is what it means. No. There's no way that a drug is beneficial if you put risk-benefit ratio. For example, Accutane, and I'll show you an example. Accutane is an acne drug. It's not a condition that needs to be treated in pregnancy, causes 50% malformation rates of the brain. That's a clear X. So it sounds logical, but it really does not work. I'll give you some examples. First, we talked 70% were C. A bigger issue, a drug may not be unsafe throughout pregnancy. A drug may be unsafe in the first trimester, but should be okay in the second and third. Some example, lithium or warfarin. I think I have a picture of warfarin. Warfarin causes chondrodysplasia punctata, a severe cartilage disease in about 8 to 10% of babies. This is a baby that is lacking much of his nose. Oftentimes they are dwarfed because of the cartilage disease. Serious. But that's in the first trimester. If a woman needs blood thinning in the second and third, there's no really reason not to be on warfarin, except that during birth, warfarin may cause excessive bleeding, so you may want to go back to heparin. So I show you the example that this ABC may not work across the whole pregnancy. It's just not describing the real truth about the drug. If you look into this labeling system, you will find out, take the benzodiazepines. Some of them are B, some are C, some are D, although it's the same receptor. And none of them was shown to be different from the other. So clearly there's no consistency. The company decides, and the FDA say yay or nay. So we have problems. Let me show you the worst problem. The worst problem is when a drug gets an X for the wrong reasons. Oral contraceptives are the most commonly prescribed drug in pregnancy. It may sound funny, but women take them to prevent pregnancy, but they fail them and continue them. So every week, women call Motherisk and such services hysterical because they didn't know they're pregnant and continued the oral contraceptive. Based on initial reports in the 60s, there were a couple of cases of kids that had sexual changes because or associated with oral contraceptives. It makes biological sense. But today we use minuscule amount compared to the 70s, and repeated studies, including 2 meta-analyses, failed to show any risk. There was a meta-analysis showing no malformations in general, and we did with our group of PharmDs, with Tom Anderson, a large study showing that there are no sexual changes either. And that's where you compared women exposed to oral contraceptive to women non-exposed. So in other words, it's not a risk. Moreover, in many European countries and other, oral contraceptives are used to maintain pregnancy after repeated abortions. So there's even an indication for oral contraceptives in some contexts. Yet, it had an X label. And the X label moved away only 2 years ago. Despite the meta-analysis published in 1992 and 1994. Just to show you, and that's back to what Adrian said, systems are not moving forward. And if physician is to use that, if he or she see an X on oral contraceptive, he or she have to tell Madame Butterfly in North Bay that she has to terminate pregnancy. Because X means malformations. Guess what? X does not mean malformation. So isn't that bizarre that in 2010, physicians cannot get from the labeling what's known today? In any other field of medicine, we update ourselves on what's known today. We do searches, we go to lectures, and it's not just on adverse events, it's on any other area of medicine. So how come we allow these ambiguous labeling in the most vulnerable time of life? Well, here is a true X. That's a child exposed to Accutane with hydrocephalus, lack of ear, which is a typical syndrome of Accutane or isotretinoin embryopathy. So this is a true X. This is a drug a woman should not be prescribed, and if she happened to be exposed, she should be informed fully about her risks. Moreover, both the FDA and Health Canada have programs how to try to prevent that. Double contraception, a whole explanation, but guess what? Human behavior defies everything, and every year we have new cases. So that's where we are. So FDA listened, and in 2000, after listening to its advisors, large consultation, they came to the conclusion that they have to abolish that ABC into simple narratives that will take people what's known. Simple. Tell them what's known today. This was the Bush era, and actually nothing moved. For about 8 years, nothing moved. And I'm not saying it, I hear it from the FDA people. It was on a shelf. Only in the last year and a half, it really began to move, and finally approved about a year ago, and here is what it will mean. It will mean a new narrative text rather than this general description that really will give physicians and other prescribers what they need to know. And it will include general information, specific fetal risks, clinical considerations, and then all the data. So you can read it and make your own mind, as we do in any other thing. I can tell any of you anything about what I read. You still may want to go and read it yourself. And oftentimes say, Koren, you didn't understand it. And that's still okay. And of course, all references, so you can go and find it. Now, what I'm going to show you now very short, when they came up with new guideline, I recruited our fellows. You know, we have the largest fellow group in ClinPharm, probably in the world, more than Stockholm and Vanderbilt. At that time, we had 11 fellows, and we chose 3 drugs to see how this will play on them. Out of the 3, we took oxycodone as an example of a narcotic that already have problems in it, why woman is on narcotic. We took misoprostol, a drug used mostly during labor. And we took oseltamivir, which is, of course, the Tamiflu, which is very relevant to what we experienced in the last year. Because of time, I will just show you the Tamiflu part. But I just want to acknowledge that Nada, Miho, and Parvaz, Chagit, Asnat, Ala, Alex, Hiraki, Hisaki, Sachi, and Facundo all worked on that. And they will all be on the papers on that. Because, of course, what we try to see, does it work? How would it look? And I'm going to be relatively short just to show you. So here's the Tamiflu. The general information section, which starts, will say something like, all pregnancies have a background risk for birth defects, which is important. So don't blame everything on the drug itself. You have to know that there is 3% malformation rate in general. In the case of influenza virus during pregnancy, the potential benefit of treating infection with Tamiflu outweighed the theoretical risk of Tamiflu in pregnancy. So here's an example of something that a physician should know when he or she are approaching pregnancy. But at the same time, Shinya Ito and a group of our fellows with our collaborators in Japan tried to put together all the Tamiflu experience that was known as a part of trying to upgrade our knowledge. And that was published in the CMAJ last year. Fetal risk summary. Here's a summary, a narrative in the way that we wrote it, of course. So that's the way we think it should look. Based on available human data, exposure to Tamiflu in early pregnancy is unlikely to be associated with a significant increase in major congenital anomalies above the background risk. Unlikely is a key word. You can never prove safety. You can collect 1,000, but if something is rare enough, you missed it. And you see a significant increase, which can be debated, how you measure those things. But that's the general feeling. Clinical considerations. Key here. Pregnant women, especially in the 3rd trimester, are known to be at higher risk for complications from infection with seasonal flu, and severe disease among pregnant women was reported during past pandemic. Key information. It's not yet a formal risk-benefit ratio. For that, you need much more. But it's to tell a guy, don't just look at the risk. Think about the risk of the untreated condition. Very critical. Here, already incorporated in what the team did, high mortality and severe complications were reported with the H1N1 influenza virus in pregnancy. There was more severe illness among pregnant women, and it has been reported, and here are the statistics. Statistics will move. There will be more cases. But the guy who is hesitating has to know that. He has to know that he put the woman at risk if he or she do not treat them. Then comes the data, and I don't go through all of it. You give a narrative of what the study showed, some maybe evaluation of its quality, and then you go on. So here, and then you go to the animal data. Very important to put it, but in the context. And animal data may be very useful or totally useless. Depends upon a lot of context, which I don't have time to make sense into now. And then the references, so the individual can go and find it and decide for himself or herself. Now, is it going to work? The proposed method is one that we use effectively in Motherisk for 25 years. We try to give a narrative to the physician or patient on what will happen if they treat or if they do not treat. But this means that industry will have an overwhelming task to review and synthesize these new statements. Industry will have to begin to work. Till now, 90% of them just cut and paste the statement I show you. We don't know, we are not interested, you are by your own. It won't work. So actually, society, through our regulators, is demanding in our industry to be responsible citizens, even for things they don't want to use in pregnancy. So we're kind of shifting responsibility to a party that didn't want to be in this. It will be very interesting to see how it will pan out. It's no question that it will be years before this system will replace the old one. How do I know? Because I still get calls from drug companies. We have a new drug. Do you think it should be an A, B, and C? And I say, oh my goodness. But that's the way. It would take many years. Now, about the system I showed you, the team, we also discussed, is it good based on what the FDA put? Because we wrote what I showed you based on their guidelines, how to write it. I don't have time to make a lot here. I'll just give you 1 or 2, 3 points, what's missing there, and we are going to communicate it with the FDA. If there are more than one drug for an indication, say Prozac, Paxil, venlafaxine, and 20 other, maybe we should say, and most of them you know are equipotent, actually, very rarely a drug of the same class showing to be superior. Maybe it makes sense to say, you know, out of that class, there are drugs with much more experience, with much larger series. So if safety is an issue, think about Prozac. Prozac is old-fashioned, but there are 25 years of use. So that's one example. Or if most drugs have less information, say any drug, triptans, indicate the sumatriptan, which is first and by nature have thousands of cases now, rather than the new guy on the block. Because physicians try to give people the best new drug. Well, not necessarily in pregnancy. And last but not least, to try to put together a risk-benefit. It's not risk-benefit the way a health economist will want to see, but a statement that most physicians will agree with, such as, it's a disaster not to treat depression in third trimester when a woman is depressed. And Alicia is going to tell you why. That type of semi-quantitative statement that most physicians are very practical people. They will understand it. Don't put them into a cloud. Give them the data, and guess what they will do? I think they will know what to do with it. I'm finishing this with a picture from Ecuador. I visited Ecuador, and this is the 80% of Ecuadorians, this is their doctor, him and thousands of him. He is standing on the street. He told me that he's 11th generation of these shamans. These are mostly herbal products that he concocts. Most people will never see the face of a doctor in their life. They cannot afford it. They go to the street and say, I have a terrible pain on the right side. And he will say, I think you should take X, and he give it to him. On average, he makes about $35 a day, which is in Ecuadorian sense a lot of money. But the reason I show it, I think this is where we are with women in pregnancy today. I think we have to move forward. Thank you.
Hi, Gidi. I had a question. We were talking, and with the previous speaker, about how we'll be putting the onus on drug companies to update the monographs, to do safety reportings. But I wonder, is there an issue in that model? Because of, as you discussed at the beginning, the drug companies don't really care particularly about treating pregnant women. It's not in their business plan. So are they the right people to be responsible for that? Should the government be seeking that responsibility in other areas?
Actually, that part, American finished in a very typical American way. They said, guys, every drug needs a registry. Interestingly enough, not just new molecules. when I won't mention names just because of confidentiality, but when a drug, a high-power drug went into generic forms, the FDA demanded all of those generic guys to start a registry. They came together and do it together. So the Americans solved it very nicely. And Canada's still debating. I don't know why. What's the big debate? It's very easy to do. So actually, these companies are now spending millions of dollars. They're not interested in the result. They, in most cases, will not publish it, and we have major issues with that. They often do not have a control group or comparison group, but at least it's demanded. So we get every year from Glaxo Wellcome and other their reports of their registries. And it has several hundred cases of this drug and this drug. It's not ideal data, but it's prospectively collected, or if it's retro, they tell you. So actually that part was resolved. The FDA told them you have to do it, otherwise you're not on the market. So actually that one was extremely simple. We still argue the quality of that data, but that's another level. That's another level. And as you heard from the previous discussions, quality of data is a big issue in this field in general, and I agree with Dr. Davis that you need different approaches together to answer. Registries are good for the first phase of a drug. Just enter the market, first few years, before it will appear on the Kaiser Permanente database, it will come to Motherisk and similar systems. So we need more than one approach. But I think the regulator have huge power if the government supports it, of course.
Because I am the regulator. It's always difficult to institute behavior change. One of the things that they may want to consider from an industry point of view is that this is actually helpful to them in terms of liability and those kinds of issues, to make sure that the information that's on their product label is up to date. So there's that aspect that we can incorporate, I think, in our discussions with industry. I mean, we do manage, even right now, in the absence of that regulatory ability to say you will do this change, we do a lot of work in Canada on trying to keep our labels up to date. The question that I had for you, Giddy, was really, have you given any thought to, because here I am, I'm putting on my evaluation sort of hat again, in terms of, if you really want physicians to change their behavior based on what's in that statement, what kind of language is enough to put them into their comfort zone that they feel, okay, I can trust this, I can rely on this, this is enough for me to believe that I'm making the best risk-benefit decision for my
I didn't have time to go through it, but a lot of Motherisk research is on how data is perceived in knowledge translation. I'll give you an example how right you are. Several years ago, a company asked us to create a label of a safe drug. Their drug was perceived safe, but it said there's no risk more than the 3% for malformations. The minute you mention malformations, so we took it out and showed physicians, patients, and others text that said 1 to 3%. And the text described a safe drug. It said, this drug is safe. And then the language. They still gave it a risk because of the text malformation. The minute we did not mention malformations, it came down. So you are very appropriately asking, what's the right language? And that should be a big discussion. That's second. First is what the element, then the knowledge transfer. How you are sure that people hear what you say, which is always a big issue in medicine, for sure. That's a very important point.
We'll just take a brief break. We had one scheduled for about 15 minutes, but if we can maybe just make it 5 or 10 minutes and then resume, then we can perhaps finish close to on time.